Hello, and thank you for visiting my poster presentation. The poster is entitled The Association of Symptom Burden with the Risk for Falls in Community Dwelling Older Adults. I am Dr. Michelle McKay, and I'm presenting on behalf of myself and my co-authors, which are listed up here in the left side here. So just to give a little bit of background on the issue that I'm discussing here today, 1 out of 4 older adults greater than or equal to 65 years of age suffer a fall each year, often with dire consequences. However, falls are not a part of normal aging and are often preventable. An underexplored area of research is the role of symptom burden as a risk for falls in older adults. Over half of outpatient visits for older adults are related to symptom management. Symptoms often co-occur, are not always linked to a chronic disease process, and are associated with an increased risk for disability, loss of independence, and decreased quality of life. Therefore, focusing on the burden of symptoms or a person's subjective experience versus a specific disease pathology or a known objective risk factors for falls may identify a unique area for falls prevention in older adults. The purpose of the current study is to identify if symptom burden severity classes, which include the subjective symptoms of pain, balance, endurance, weakness, sleep, hearing, anxiety, and vision, are associated with time to first fall and falling within 1 year. A secondary analysis of the Mobilized Boston data set, which examined novel risk factors for falls in a population-based cohort of older adults, which included a total of 765 older adults who were 65 years of age and older, was conducted. Previous research on symptom burden within this data set has been done by this research group and is in the process of being published. But through that research, we identified 4 distinct classes of overall symptom burden. The mild severity group, which was about 30% of that 700 those 700 older adults, the moderate severity group, which is about 50%, the moderate severe, which was about 10%, and the severe, which was about 8%. The results here are an extension of that previous work. The methods that were used, the descriptive statistics were calculated for symptom categories, demographic comorbidity variables, and falls data. 2 different measurements of the response were considered: time to first fall and an indicator of falling within 12 months after a baseline measurement. Cox proportional hazard models were used to model the associations between the symptom severity class and demographic comorbidity variables and the time to first fall, both one at a time and jointly in a multiple Cox pH model. Logistic regression models were used to model the associations between the symptom severity class and demographic comorbidity variables and an indicator of falling within 12 months. Variables were again considered one at a time and in multiple logistic regression models, with the final model chosen through stepwide AIC. Model assumptions were checked for all fitted models. Statistical tests were conducted using a 0.05 significance threshold. In the one at a time Cox pH models for time to first fall, the hazard of falling was found to increase with symptom severity level. Each level increase of symptom severity is associated with an increased hazard of falling with a hazard ratio of 1.44. If you look at that first colorful graph on the left here, you can see that around 50% of the persons in the high symptom severity class experienced a fall within the following 150 days in comparison to other groups where the risk to first fall is longer, with 300 days, around 300 days for the moderate to severe, 400 days for the moderate group, and 860 days for the mild group. This second graph on the right is just a zoomed in version of the left graph, where you can see the differences in probability of not falling between the 4 severity groups at that 150-day cutoff here. So you can see the probability of not falling here, and you can see the differences in the severity groups here. Also, with each level increase in symptom severity class, there's an associated increased risk for falls within the first year with an odds ratio of 1.91. And you can see this in the bar graph, shows the percent of individuals within each symptom severity class that will experience a fall within 1 year. Even at the mild group, almost 40% here, so between 30 and 40%, will experience a fall within that first year. This research helps us to understand that the care of community dwelling older adults can and may be enhanced by the identification and improvement of the range of symptoms that they experience. Using a symptom-based treatment approach may lead to a reduction in negative outcomes associated with falls, including injury, disability, reduced quality of life, and death. The study results can assist, hopefully, with the development of a clinically useful symptom burden profile tool that can be used by healthcare professionals to identify those older adults that are at highest risk for falls and for those with an increased symptom burden. And also for the development of interventions focused on managing symptom burden for older adults. And hopefully that could lead to a decreased risk for falls as well. Thank you for attending this poster presentation. We do have some of our graphs or our tables over here of the data that is reported. You can contact me at michelle.mckay@villanova.edu if you have any further questions or for any supporting references. Thank you for your time.